Thank you so much, Matteo and Monica, for this invitation to speak at this meeting. I have to say it's my first visit to Prague, and I'm totally bowled over, just walking through the city and seeing this 2,000 years of history in so many different places. So thank you for this opportunity. Just listening to Hamdi, I think the resources they have available in Qatar is more than we have in the entire continent of Africa. So it's a very different scenario that we're looking at, and very interesting to think about how we can make a difference despite the fact that we may not have the resources. So many of you may be aware that South Africa hosted the G20 for the past year, and their byline was solidarity, equity, and sustainability. And I think this is something that we think about as well. So I think in this meeting, what I've heard also in terms of IC and EP PerMed is that it is about solidarity, working together, about thinking about equity, which is very hard to do, and sustainability of the programs that we have. So thank you. So I did particularly put into the title the word genomic. We've had some discussion about personalized medicine, precision medicine, and the definitions. And my focus is really about the genetics aspect, although I realize that that is not nearly everything we have to be looking at when we think about personalized medicine. I think one of the success stories of personalized medicine is sickle cell anemia. And this has gone all the way from understanding the science to thinking about prevention. And eventually now we have a cure. And, I think we need to frame the challenge. And the challenge is that in Africa, 3/4 of the people with sickle cell anemia live. And this affects 5.6 million people and so many children born every year. But what do we offer them in terms of personalized medicine? When we think about prevention, we did the first prenatal diagnosis for sickle cell anemia in 1984, and it was so significant at the time that we actually published it. But at the moment, prevention is not available in most African countries through prenatal diagnosis. And in some countries, because of religious and cultural reasons, will never be an option. But they are starting to look at premarital testing and thinking about prevention in that way. Diagnosis is simple, but treatment, even hydroxyurea, is not available in most African countries. And that is a problem. But then we think about what is happening in the developed world, and what we see is that there's now a cure for sickle cell. But we have to think about equity and affordability, and will this ever be an option in Africa? So at the moment, the cure costs $2 to $3 million per person, and is only available in scenarios where you have transplant facilities, which we don't in most African countries. So to think about this, we need to think about getting research that will look at in vivo rather than ex vivo gene therapy for sickle cell. But I like this as an example because it shows where we could be, but we have to be more innovative in terms of how we roll this out to more people where it is most needed. So the human genome is obviously at the foundation of what we do in genomics, and it interests me that we have made so much progress through technological advances that things are now more affordable. But I think the challenges are still in the annotation of the human genome, and that is still very Eurocentric because of the data that we have. And it's very nice to see this progression towards the human pangenome reference, where we are now seeing inclusion of individuals from different ethnic backgrounds, because they give us additional information. I'm interested also in the discussion about, moving genomics or precision medicine into the area of artificial intelligence, machine learning, deep learning, and thinking how those models are still based primarily on data that is not diverse, that we need more diverse data. So our institute is named after Sidney Brenner because he was born in South Africa and got his foundational training and education there before moving to the UK. But these two comments that he made when he shared the Nobel Prize in 2002 are still relevant today. And the first is that we're still struggling to really interpret what genetic variation means in terms of the phenotype. And I think so many people have said this over so many years, but it is still our task for the future. And then the second point that he makes is that we've been looking at disease in a very genocentric way, and we need to start thinking more about the multi-omics, looking at the cellular level and the impact on the individual. So I think, you know, in many ways he was before his time when he said this, but these challenges remain with us today. So global partnerships, I think, are essential in personalized medicine. There's so much that you have done, and reaching especially the countries that are most need of these interventions is really a huge challenge. So we often think of, you know, bottom-up science, and I think a lot of science is driven by curiosity, by scientists getting together, wanting to solve a problem. And that is the discovery part. But we really need to emphasize both data diversity and also data complexity. We know that there are so many levels that we need to be looking at. We cannot look at it just from a genomic perspective. But this means that we also need global resources. We need resources that everybody can tap into and that will be relevant when they're thinking about personalized medicine in their countries. So there are many partnerships, international partnerships and organizations that look at data standards, and some of them are mentioned here. There are many international partnerships, including the one that is hosting us here at the moment, that are really important in terms of sharing knowledge, building partnerships and networks. And of course, there is international guidance, which we also need in terms of equity and sustainability. So it is telling that the first report of the WHO Science Council was actually about genomics. And it made this very important statement that current uses and future applications of genomic technologies are critical for improving health and livelihood of people in all parts of the world, regardless of economic status. And is this something which is achievable? But one of the things they asked for in this report was to establish a technical advisory committee for genomics. And that committee has now come up with a series of guidelines for the ethical the ethical way of getting data together, but also in terms of how it is used and shared. And I think, you know, this committee, and disclaimer, I am part of it, really got together with multiple stakeholders in terms of trying to understand what the issues are and coming up with guidelines that will be applicable no matter where you are in the world. So it's very principle-based. And we always say that this is not going to be the implementation side of it, that implementation has to happen at a national level. I was interested in looking at North-South country collaborations, and this is an analysis that was done by Nature, and just looked at their publications over a number of years and looking at what the partnerships are. And I think, you know, we're seeing more of these happening, and we need to make sure that the Global South is better represented in research and development. And when we look at publication trends over a 5-year period, what we can see is that, you know, there wasn't anything that said personalized medicine or precision medicine. So I was thinking about medical biotechnology, but then also looking at bioinformatics and computational biology. And what we can see is that there's been steady you know, sort of research and discovery in medical biotechnology. But in the last 2 years, what we've seen is a very steep increase in papers related to bioinformatics and computational biology. And that is really because data is increasing in the world. And through these national genome projects, we just have so much data that can now be analyzed and looked at in different ways. So Africa has a population of about 1.6 billion individuals, and we're really facing a multi-morbidity situation now where it's not only about infectious diseases, but also the rise in non-communicable diseases. But most of the research funding has still emphasized infections, and we are happy to see that there is a shift happening. Because we don't have nearly enough data, and if we want to implement personalized medicine strategies, we will need more data from the continent. But generally, part of our challenge is that we have a poor health infrastructure, and we also have a low skills base. We don't have enough people with the right skills. So the workforce development is absolutely critical to promoting personalized medicine. So I'm just going to highlight 3 initiatives that have been partnerships within Africa that have made a big difference, I think. So there was a 10-year project called Human Hereditary and Health in Africa, H3 Africa, which brought together researchers and built a network in the continent, but also with partnerships beyond Africa. And those networks still persist. And although a lot of research was done, over 700 publications, very little of it is actually implemented in clinical practice. And in that way, we have so much more work to do. Then, of course, you've heard a lot already this morning about this initiative called ICPerMed, where over a 4-year period, there was a lot of consultation and just trying to understand what resources exist in Africa and how African countries and regions can work together better. And then the other and third project is now the data science for health discovery and innovation in Africa, which is currently in its first 5-year term, and of course being challenged now by what is happening in the US. But that is about far more than the genomics. It's about bringing all types of data sets together for personalized medicine. So Monica didn't put up a slide, but I really like the outcomes of the ICPerMed initiative in that there is this policy brief which tells us about what is happening in different countries of Africa and which of them are more ready to start thinking about personalized medicine. So this took into account, what research is being done, what collaborations are going on, what is the health infrastructure. And you can see that there's great diversity across the continent, that South Africa and Egypt are better resourced, and many other countries now are building resources, but they're large swathes of Africa where very little is happening. And the outcome was this action plan, and very nice to see that there are now funding opportunities coming out of the action plan, which will help realize some of the vision and the dreams that this ICPerMed came up with. So we often think about African genetic diversity as a scientific treasure. And our species, modern humans, arose in Africa about 200,000 years ago. And from about 70,000 years ago, there have been multiple waves of migration out of the country, but also migration coming back into the country. But because of that deep evolutionary history, African genomes have more diversity than we will see in the rest of the world. And we captured some of this in a paper that we wrote under the H3 Africa umbrella. And this was about doing whole genome sequencing of just over 400 human genomes from 50 ethnolinguistic groups. But as you can appreciate, this doesn't cover the whole of Africa, which has about 2,000 ethnolinguistic groups. But I want you to look just briefly at that principal component analysis plot at the bottom, because that is looking at the relationship between different African countries and realizing that within the continent there is enormous diversity. And when we develop solutions in one part of Africa, they may not equally translate to other parts of Africa. So on the first axis, we're seeing the split between East Africa and the rest of Africa. And on the second axis, going all the way from west to central to South Africa. And before we did the study, we thought of these populations as being sort of very discrete. But of course, the more you add different populations, the more you see that it's a continuum across the continent, and that populations that are next to one another are more likely to be more similar. But there is this decline rather than discreteness. And what we further showed is that almost all African individuals are also highly admixed internally, and that is very important. So I wanted to give a few examples of personalized medicine impact of research that has been done both in rare Mendelian disorders and then in complex genetic diseases. And what we do see, and which is not often captured, is that there is tremendous allelic and locus heterogeneity in African populations. Some of the different mutations that we see in the same genes are relevant to these different conditions and need to be taken into consideration, especially when we see diaspora populations from Africa and the rest of the world. But what's also very important is that there is locus heterogeneity, which is present in African populations that we don't see elsewhere in the world. And I always like the example of Huntington disease, because I think if you have an African patient who exhibits the signs and symptoms of Huntington's disease, and you look for the triplet expansion on chromosome 4 and you don't find it, you might say this is not Huntington's disease, because you haven't looked at the second locus, which is relatively common in African populations. So it's really important that that research is done in the African families. This is one of my favorite examples, and this was a partnership between South Africa and a Norwegian scientist, and this is about a very rare skin disease called keratolytic winter erythema. And it took us 20 years to go from identifying the position of the locus on chromosome 8 to actually finding the mutation. But we couldn't have done this if it wasn't for a collaboration. And here you can see it was described in 1970. It was brought back to a common founder, Francois-René Duminy, who came from France and was a mariner and left his genes behind. So then now many families in South Africa with this condition. But it's also diagnosed in other places. And I just want to show you this data because I think this was such a wonderful collaboration and story. So when you look at the two blue bars, those are parts of the genome that are duplicated. And the top one is the duplication in the South African families. They all have exactly the same. And the other one is the duplication in the Norwegian families. And it's only because of the overlap of the duplication that we could say that the cause of this disease was the duplication of an enhancer element that upregulates cathepsin B. And what you can see in those skin samples is that in the affected individuals, there's upregulation of cathepsin B, which leads to the redness and peeling of the palms. And I love this example. Another example that I want to bring to you is kidney disease, and this is kidney disease in children. And it's more common in African populations than other places. And we know that there are ethnic differences as well. And the children are either sensitive to steroids, which means that they respond, or they're resistant. And when they are resistant to steroid treatment, they often progress to kidney failure very quickly. And together with US collaborators, we were able to identify a mutation in the gene, the podocin gene, that is associated with steroid-resistant kidney disease. And this is an autosomal recessive condition. And what you can see in the Kaplan-Meier plot there is that survival of the kidney is very poor when you have both steroid resistance and this particular genetic mutation. And the utility of this has been that it's been implemented in treatment guidance, but also it is a prognostic indicator. And very importantly, it can be used for genetic counseling and family planning. So I think to me, this is a success story of personalized medicine, which is now being implemented in our National Health Laboratory Service in South Africa. Another example is breast cancer, which is also as common amongst women in Africa as it is elsewhere in the world. But we know that the outcome for African patients is often worse than it is for those of European origin. And the most common treatment of estrogen receptor positive cancers is tamoxifen. But tamoxifen is not the active part of the drug. It has to be converted to endoxifen by the product of a gene called CYP2D6. And what they've shown in terms of pharmacokinetics is that many of the African women who are treated with tamoxifen do not reach therapeutic levels of endoxifen. So the obvious thing is to look at the enzyme which converts tamoxifen to endoxifen. And there is a variant called the star 17 variant, which is more common in Africa, not really found in European populations. And this particular variant leads to intermediate metabolizers, and which means that with the same dose, which is recommended in a European setting, these individuals don't reach therapeutic levels of the endoxifen and therefore have a very poor outcome. So the solution is simple: you double the dose. But sadly, this is not yet implemented in South Africa or in other parts of Africa, because really what should be happening is in terms of policy, it should be mandated that women of African ancestry who are being treated for breast cancer with tamoxifen should have this test done so that they can be dosed appropriately. So this now brings me to examples in complex multifactorial diseases. I know we've spoken a little bit about polygenic scores and understanding that in this case, having large numbers of individuals is really critical. So I just will have a few examples of studies that are fairly recent that have taught us quite a lot. So this is about prostate cancer in African men, and this was a collaboration between multiple African countries and the US. And what you can see is that it's a fairly modest study of just 4,000 affected individuals, 3,500 controls across 5 different African countries. And what it showed was that the performance was similar to multi-ethnic or European studies in terms of the outcomes. And some of the conclusions are that the associations were often in areas where there was a neutral evolution. The contributions were recent mutations, genetic drift, and bottlenecks that affected the variants that were actually associated with prostate cancer. But very importantly, the effect sizes of individual variants differed across different African countries. And so that tells us something about the importance of collecting data on the environment as well. And I think that is well recognized by everybody. And again, brings us back to, Africa should not be treated as a single homogeneous group, but we really need to look at the diversity. A little bit earlier, I think it was Hamdi who mentioned the A Million Veteran Program, or somebody else did, because that is a study in the US, but it has people with different ethnic backgrounds, and therefore it becomes incredibly useful when you're trying to look at research. And this is work that's done by a woman, Catherine Chianjo, who's actually originally from the Cameroon, but working in the US. And she was really interested in the genetic risk for coronary artery disease. And what you can see in this GWAS Manhattan plot is that the locus which is most important is a locus on the short arm of chromosome 9. But what Catherine decided to do was to divide up the Million Veteran Program into those individuals who self-identify as white Americans and those who self-identify as Black Americans. And what she showed was that most of the signal on 9p actually came from the white Americans. And then she decided to look at what was happening in the Black Americans. This is now self-identified. And she looked specifically at haplotypes around the 9p21 region. And so she could identify individuals who had 2 African haplotypes, those who had 1 African, 1 European haplotype, and those who had 2 European haplotypes. And you can see the numbers there in the self-identified Black Africans. And what you can see is when you look at the allele frequencies of the variants that provide the signal to 9p21, is that if you look at the frequencies in the individuals who have 2 European ancestries or haplotypes in that region, there's very good correlation. But when you look at those with only African ancestry or haplotypes in that region, there's a lot of differences between the European frequencies and those in those individuals. So I think, this is very important in terms of polygenic scores when we're looking at prediction or susceptibility to disease. And this was another study which I found very interesting, looking at if we include diverse populations in our studies, are we really improving our predictability in terms of polygenic scores in different populations? And again, this comes back to the Million Veteran Program, where the first group of signals are from African individuals, the second, or what was called previously Black Americans, then white Americans, then Hispanics, and the last one is actually looking at people of Asian origin. But what you can see is that the multi-ethnic polygenic score performs best in each of those groups. But when you look at as a group at the African populations, you can see that they are performing far worse than the other populations. And this has a lot to do with the data that is used to generate these scores. And I was really interested in this particular figure, because what it says is, in the final polygenic score, what are the signals that weigh most? And when you can look at these different diseases, you can see that, most of the explanation is for coronary artery disease by far. But when you look at the contributions and where they come from, they're mostly from European populations, and that is the light blue, and there's hardly anything from African populations. And I think that that's really telling, because I always wonder if we had millions of African participants, would we be seeing a very different pattern? So many of you will be familiar with the GWAS Diversity Monitor, and I just want to contrast for you the 2024 figures and the 2025 figures. So first of all, this is talking about the number of participants who participate in these genome-wide association studies. And in 2024, about 95% were of European origin and only 0.19% of African origin. And what is nice about this monitor is that it's separating the diaspora admixed African individuals from those of the continent. But I want you to see what has happened in just 1 year. So we're now seeing a relative proportion of European ancestry participants going down, which is a good thing because it means that we're seeing more diversity and more inclusion. And where the rises come is in Asian population, in admixed African American and Afro-Caribbean population. But what you can see now is that the contribution of continental African individuals relatively is going down because we're not seeing the same increase in continental African research, and that is a problem. So I just want to show you very briefly two examples of how we're trying to generate resources from Africa that can benefit the world. And one of them is looking at regulatory variants. And I was quite interested in looking at the alpha gene, and that is a deep learning algorithm to try and predict regulatory variants. But they have not included data from Africa. And this is a resource that we have now generated, which we hope will make a contribution, but it's still very small. And this was an interesting partnership. We spoke so much this morning about industry partnership, and this was a partnership between an American venture capital company called Variant Bio and an H3 Africa project called Awigen. And these data are now available to the scientific community, but we've also written a piece on benefit sharing and how you can, when you negotiate with industry partners, also negotiate benefit. And one of the things about Variant Bio is that they have an affordable medicines pledge. So when they develop a drug or something, that will be made affordable to the countries that have contributed to generating the research. But I think what is important, and one of the outcomes, there have been many different outcomes, is that most of us use GTEx to look at for regulatory variants from different tissues. And with the same sample size from an African population, on average, we're finding 2.5 more variants per gene that are regulatory variants. So this database can also help people who have GWAS signals in non-genic regions to make more sense of them. So I think, that's a valuable resource. Then the other study that I wanted to bring to your attention is the expanding of the gut microbiome by including African samples. And this was a study of just 1,800 individuals from 4 different African countries. And this has led to novel discovery of bacteria and viruses that have never been documented before. And we don't know what they do. We're trying to understand their relationship to health. And what we see is that there are differences in lifestyle, in geographic areas, but also in terms of health status. And again, these data are available for people to look at. And then finally, in terms of African contributions, we talk about the workforce. And through initiatives like H3 Africa, EU Africa PerMed, we've tried to work on the workforce. And I think we have a problem still in Africa in terms of retention of the workforce. But we have incredible talent. And if we think that the population expansion in Africa is going to increase tremendously in the next 30 years, this is a resource that, again, can be available more widely. So we've spoken a lot about, personalized medicine being an ecosystem and needs so many contributions. We need data, we need a diversity of data, but we need the skilled professionals and the data science capabilities. But I think we've spoken about the fact that this has to happen in the context of a health system, and this has to happen at a national level. And then we need, our policies and guidelines, and very importantly, our public awareness of what personalized medicine is. But we need more research. And I think in Africa, what we really need is that political will or government support to make sure that personalized medicine can make a difference. So I'm sure you're all aware of this, and this is nothing new, but partnerships can happen at many different levels. And that is important to think about because the needs of the partnerships vary according to who is making it. But to be effective, and I think, you were saying that earlier as well, Monica, is, you need to have a proper shared vision and goals, and they have to be co-created. It doesn't help if you create it in one place and then try and enforce it somewhere else. It has to be something that is done together. So, balanced intellectual contributions. We want to see balanced partnerships. We don't want to see a David and a Goliath scenario. So it's very important that we think about how we can enable the sharing of resources and benefits, and also how we ensure at all levels that we have effective communication and frequent communication so that everybody's on the same page. So I know that this was about the last 10 years, but I also think often about the future and where this is going. And, data is not equal, but we're now collecting data at all these different levels, but not enough and not in a balanced way across the world. But it faces many challenges, and I know that many of you are working on how we address this. But it's exacerbated when the complexity is increased and you have many different partners and countries involved. But we do have an issue in terms of data heterogeneity and integration. But most importantly, and probably the hardest, is also the issue of governance and ownership of data and how you share it responsibly. And then we have to guard against algorithm bias, because if it is primarily trained in European populations, it's never going to be appropriate for other places in the world. And I think that this is really important because we need to think about the equity issues. We also need to think about, these AI outputs and really whether we can explain what they are and how they came about and whether they're appropriate. And we need to think about accountability. What will happen when things go wrong or when we use something that is inappropriate. So I think this is really incredibly important. So I think in this last slide, just to talk about balance and equity, I think, often partnerships are very unequal because resources are unequal, skills base is unequal, and it feels like it's a one-way, sort of benefit. And that's not right. What we really need to think about is balance. We need to think about balance at so many different levels, because it is at the planning of the project and deciding what the priorities are, what the roles are of the different partners, and then, building capacity where it is necessary. And I think in some ways, everything is more complex. It's not only bilateral, it's multilateral, but it's also iterative processes that need to be gone through as everybody learns and as we ensure that more people can actually benefit. And I love this Ghanaian proverb because I think, we often say too many cooks spoil the broth, but this one says too much meat does not spoil the soup. And I think in terms of personalized medicine, this is what holds. We need more input, we need more data from more places to actually really make a difference. And I think just as my very last slide is to say, I'd just like to thank our team at the Sydney Brenner Institute who inspire me to do more. Thank you so much.
Thank you very much, Michelle, for this inspiring presentation and for telling us that African situation is only the tip of the iceberg of what it can offer in terms of development of personalized medicine. We now welcome questions from the audience. Are there any raised hands? Maud in front here. Please.
Yeah, thank you so much, Michelle, for this inspiring presentation, actually, with the little means that you have. I have a quick question. You mentioned the example of tamoxifen in breast cancer. And you mentioned also that you know that doubling the dose will make an effect, but it's not implemented. Can you please tell us why it's not implemented? Is it a matter of going through a clinical study, for example, or just a matter of resources? Thank you.
Thank you, Maud. That's a great question. And I think it's multi-layered, and we've spoken about, the system. So in some ways, we probably have to have more evidence to have this go through a drug, sort of, or a medical device, as they call these tests, and then be implemented. So I think we kind of lack the critical mass to do all the different stages, because we've got the researchers who do the research, but then to go to the policy level and implement it, I think is really tough. And you would think it's such an obvious benefit that everybody would do it, but there are just not enough people around to actually make it happen. But it makes me sad to hear that, because obviously you want this to be implemented, and it should be implemented across Africa, because we can look at the frequency of that variant in different African populations.
Martina?
In the beginning, you were speaking about sickle cell and the treatments, and mentioning the potential for in vivo gene editing. Could you tell us a bit more about what's ongoing in that field in terms of trials or whatever?
Martina, I don't actually know, but that is what I would like to see, because I know if there's ex vivo gene therapy, it's never going to work in Africa, because we don't have everything else that goes with it, the laboratories, the infrastructure for organ transplants, that sort of thing. So unless we have something that is in vivo, I think it's never going to make a difference. And so I would like to encourage the international, community through partnership to actually look at how that can be done. I've had some conversations with people who think it might be possible to actually target, specific stem cells, blood. Yeah.
Yes, Ron over there.
Yeah, thank you very much. Ron van Schijk from Erasmus University Medical Center. Thank you very much for a very clear presentation. I was very intrigued by your remark of the star 17 and 26 and the tamoxifen in the African population, because one of the aspects that I have in my mind, also from Magnus Ingman Sundberg, is that the gene duplication is very frequently encountered in the African population, up to 30%. I know that was done in Ethiopia. So I was now wondering, are we now grouping the whole of Africa too much together? So is there diversity in there, or are we in the 48% of women that do not reach the proper endoxifen concentration? Would it be a combination of the poor metabolizers not activating endoxifen and the ultra-rapid metabolizers giving too much endoxifen and the side effects and thus becoming non-compliant? I'm sorry, it's a complex question, but I was very intrigued by your remark there. So do you have any comment on that?
So thank you very much. This is research done by my colleagues, but I think, you're right to say that Africa should not be treated as a homogeneous place, that there will be different things in different places. So we need more information, and I think we don't have nearly enough data to really understand that well enough. So I would love to put you in touch with our researchers to kind of explore that a little bit more. But I think the more we look, the more we see new things in Africa, and that can benefit, so many other people across the world.
Thank you very much.
Thank you, Michelle. This was very, very interesting. I'm wondering, so you're finding a lot of different functional alleles, let's say, for lots of different diseases. And of course, African people are in Africa, but they're everywhere in the world as well. Is there a platform or a database that includes this type of variants? Are you part of CleanGen, for instance? Do you have, how can we access this information? And how can it be disseminated? Because I don't think, I know, maybe clinical geneticists and other clinicians are not aware of this in general.
Yeah, thank you very much for that question. So the regulatory resource we've actually put on EGA, and so it can be accessed through a request to a data access committee. But I've been talking to my colleagues about making it available as a track in Ensemble, so that it's more findable, so that people, when they find variants associated in a genome-wide association study, they could maybe show that it has an impact in the African population in terms of gene regulation. So we want to make it more findable. I'm very excited about the kinds of things that we're finding. So for instance, kidney disease is more common in African populations, and people have not really known why. And we use, again, very Eurocentric measures of kidney disease. So we use, serum creatinine to measure eGFR. But research that we've just recently done and haven't published yet shows that there are variants in a gene that affects creatine expression, which then affects creatinine, so that in general, people from Africa have higher creatinine levels if they have these variants, which are quite common. And so there's almost like an overdiagnosis of kidney disease in African populations, which is not a good thing because we have to identify the individuals who actually need the treatment. And they've also found now that cystatin C is a much better measure of kidney function in people of African origin than is creatinine. So I think, there's some very interesting things that tell us also about pathways, and that might help with kidney disease treatment anywhere else.
Seems that it's needed to reach healthcare or clinicians.
Yes, yes.
Michelle will not leave, so we have a panel discussion. So there's still one question?
Okay. Hi, Elina Ost, University of Oslo. So thank you for a very nice presentation. So I was wondering, this is as a health economist, I was wondering, so obviously there's some very important features of precision medicine in Africa, potentially with a huge health benefit. So how do you work in interaction with, in order to access it? It's about the coverage, being able to access the treatment or the diagnostics, and as you also mentioned, about personnel, which is a huge barrier, not only in precision medicine, but in a lot of others. So how do you work? Do you also work in interaction on that level to implement it?
So I think that, those are very complex things to understand. I'm very happy that Rizwana Mia is here from the South African Medical Research Council, because she's done a lot of work, and they have in terms of supporting research. But I think, we often think that you can do research and implementation just quickly one after the other, but it needs a different group of people. You need people with different disciplines, expertise, and so on to actually take it to where it can make a difference. And I think, that is a challenge. I can see that it's a challenge in Europe, but it's even more so in African countries, because our health systems are often geared at primary health. So they're primarily dealing with infectious diseases. So now we're seeing, as our population is aging, we're seeing far more non-communicable diseases emerging. And it's almost like, everything has to be treated together. And there are big discussions about, whether patients who have multiple conditions should be going to one clinic only, because at the moment they'll go to one clinic for their diabetes treatment, to another one for their HIV treatment. And, you never have that sort of person being evaluated altogether. And so I think we have huge challenges. And I think we also have a challenge in terms of, we do so much training, but we lose a lot. And I think I mentioned that challenge of the retention of the workforce. And part of it is because our systems are not working very well. And if we could get those to work better, I think that would be an enormous help. But it is about priority setting, and it is complicated. Yeah.
Okay, one last question from Iñaki, and then we go for the coffee break.
Yeah, thank you very much for this comprehensive presentation. We work with some colleagues from Tanzania, and they told us that even it was in the course that we had in Zaragoza around building capacities, and it was very interesting because they were saying that there is much more variability in Africa than in Europe. And I don't know if you have found a similar pathway in your studies, and on the other side, which are the consequences for pharmacogenomics?
Yeah, I think, you're quite right. There is a lot more variability genetically in Africa. And I think it's, again, that what we develop in one part of Africa may not necessarily apply in another. So we need data, not just from one or two regions, but from lots of populations. And, we always say that political boundaries are not good boundaries in terms of peoples, because people migrate and often, are in bigger regions. So how do we decide, how to, sort of say what is appropriate for whom? So that is why I keep on thinking we actually need much more data from Africa than we need from the rest of the world to really understand, what the pharmacogenetic variants are, for example. So I think we have an enormous job ahead of us. And it is good to think about partnerships with Europe, other parts of the world, and how those can actually really help us build these data resources that we need to understand more.
Thank you very much, Michelle.